Hi, it's Dr. Russ. I had an idea for a new kind of video and I'm going to try it out today. I hope you like it. I'm going to talk you through kind of what's been going on in my practice for the last month or so. A few cases that came in and do some clinical pearls and how I worked through those cases. And then at the end, talk about kind of more generally how things are going with the business and how things are going with me in relation to my business. So we'll just call it touching base. Pearls and Insights from Practice, April 2024. If you don't know me, welcome to my channel. Welcome to this video. My name's Dr. David Russ. I'm a chiropractor. I practice in Portland, Oregon. I've been in practice for about 25 years, amazingly. And I have this channel where I do treatment videos and mindful movement and exercise and sometimes just talk to you about practice and my thoughts about practice. And that's what we're going to do today. So, hey, what walked in this month? Well, we had a new patient with pain and tingling in the front of the right thigh. And so anytime there's tingling, we are concerned about the potential for a neurological issue, as we were in this case. This had been going on for about 5 weeks, was only on the right side, and aching and tingling. So the things I was thinking about anytime there's tingling in an extremity, thinking about the potential for radiculopathy, some issue affecting the nerve root in the front of the thigh. That's going to be the L2-3 segments, upper lumbar discs, which are not that commonly injured. It does happen, but as you go farther down the lumbar spine, the incidence of injury just increases exponentially as you go down. So it's not unheard of to have an L2 or L3 herniation and L2 or L3 radiculopathy, but not that common. More common in terms of nerve entrapment for the front of the thigh would be an entrapment of the femoral nerve. And we'll look a little bit at the anatomy of that and why that happens. And then always we have to keep in our minds the potential that there's some inflammatory or autoimmune neuropathy happening. And so what else was going on with her? She had a little bit of lower back pain. It was not in the L2-3 region of the spine. It was more in the lumbosacral region. She didn't have any recent injury. There was no slip and fall. There was no car crash. She hadn't fallen off her bike, and she hadn't had any recent illness. Without a recent illness, I'm less inclined to think of an inflammatory neuropathy. Without a recent injury, I'm less inclined to think of a disc problem or some other issue in the spine creating radiculopathy. And the fact that her low back pain was pretty mild told me this was not probably a severe injury or a very, very serious case. She stood normally. There was no antalgia. Her gait was totally normal. When I asked her to do a Valsalva, which I ask a lot of my patients to do, take a deep breath in, hold your breath, and bear down like you're trying to push out a bowel movement. If it's negative, that means there's no increased extremity pain. A lot of times people with a low back injury will have increased lower back pain with a Valsalva or a cough or a sneeze. That's not necessarily going to mean that they have a radicular problem. It's when that pain shoots down into the lower extremity. So I wanted to know, when she bears down, does that increase her femoral nerve issue, that front of the thigh aching and tingling? And it didn't. So that made me feel good. That made me feel like we had more of a green light to proceed. Also, her right psoas was a little weak. Otherwise, her motor function was totally normal. Her reflexes were normal and her sensation was intact. This happens a lot when folks complain of numbness or tingling. And you do a sensory exam with the Wartenberg wheel. You run that along their skin. You ask if they can differentiate sharp versus dull. You can do 2-point discrimination, have them close their eyes and put either one finger or two fingers down on their skin and see if they can differentiate what one finger versus two fingers feels like. That's called 2-point discrimination, and that's part of proprioception, and it's a pretty sensitive test for sensory deficit. She didn't have any sensory deficits. Her reflexes were totally normal. Her abdomen was normal. Her review of systems was normal. So she basically is healthy. Sometimes a femoral nerve entrapment will be from a mass in the abdomen or the pelvis. It could be an intestinal mass or distended large intestine on the right side, particularly the cecum is there. It's not common, but it does happen. Or a tumor or a growth on an ovary or a uterus. This was a female patient, so that was a possibility. But all that was normal, and her menses were normal, and all of that was fine. So I gently but directly palpated on the iliacus and the psoas on that right side, and bingo, it lit up her low back. Right, the low back pain was coming from the psoas, and it also increased the tingling sensation in her thigh. So I thought that was diagnostic. And I do say gentle palpation. It's important when you're palpating for tenderness and trying to reproduce pain. And reproducing pain with palpation is a really important and wonderful clinical diagnostic tool for body workers. If you can get your hands on it and the patient says, yes, that's it, that's really great. But you have to be careful not to dig too deep, because if you press hard enough, it's going to hurt. And it's almost like people will tell you whatever you want them to tell you if that'll get you to stop poking them really hard, because they don't like that. So gentle palpation. So I diagnosed a femoral nerve entrapment in the iliopsoas hip area, and there was also hip flexor dysfunction and hip joint dysfunction. And yeah, this happened. I think we started working together about a month ago, and I asked her for 6 sessions, and I said, we can free up the nerve. We can get your hip working better. We can open up the psoas and iliacus, and probably the low back pain will get better first. And the thigh pain will get better next, and then the tingling will be the last thing. Because just because you release the entrapment of the nerve, it doesn't always make the nerve stop complaining right away. So the tingling in the leg, the tingling in the thigh is the femoral nerve complaining because it doesn't like to be squished. So you unsquish it, but it's still irritated, and nerve tissue heals pretty slowly. So I said probably it's going to take some weeks for that to happen. So we did really well. She showed up for all of her appointments, showed up on time, ready to work. We got a lot of work done. We focused a lot on the right hip. We did do some work on the left hip and the lumbosacral joint as well. There was no cracking. It was all induction and myofascial work and trigger point work. And it's worked really well. Her low back pain resolved really quickly. The thigh pain was next, and her tingling in the thigh was now intermittent. So yeah, we had 6 sessions, and then I said, let's go 2 weeks and see what happens. So I think she'll be back next week or the week after, and we'll see how she's doing. We also had a lot of this chronic lumbar and hip pain in older men. So I'm 54, I'll be 55 this year. I have a history of a disc injury, a pretty bad one. So I feel like this is my future. This is a lot of futures for a lot of people. You get older and your low back gets degenerative. You get degenerative discs and facets. It gets dry down there. You lose your lordosis. You lose your mobility in there, and it gets irritated. And fortunately, this is right up our alley. The work that we do is just perfect for this, and we were able to help all 3 of them. All 3 had history of disc injury and radiculopathy. One of them had had surgery. This particular fellow I really enjoy working with. He is retired, and he is a photographer. And I have several patients who are retired and are now able to travel the world, pursuing the magical photographs that they're looking for. And I'm just so happy for them. It takes a bit of a toll on the body, traveling long distances, lugging lots of camera equipment all over the place. So when they come back, they come see me, and I'm always happy to see them and see you. So yeah, he had come to me originally, probably a couple of years ago. We were still wearing masks. It was still during COVID, and he had low back pain and radiculopathy. And I saw his images, and I thought maybe this is too far gone, but let's give this a try. And he said, sure. So we gave it a really good try. I saw him a couple times a week for about 4 or 6 weeks, and he would always feel better getting up off the table and feel a little sore the next day, but feel okay for a couple, 3 days. But he would always, within 3, 4 days, go right back to where he had been symptom-wise when he first came in. So he opted for surgery, and he had a 2-level microdiscectomy. It worked great. I supported that decision. So he was one of the 3. They all 3 had dull aching in the low back, stiffness of movement, right? Hard to bend over, hard to get up from sitting, and radiation of that pain down the hip and the hamstring. So that radiation of pain is not always radiculopathy. Sometimes it's the hamstring, sometimes it's the glute, sometimes it'll be a sciatic nerve irritation happening under the lower SI joint where that nerve comes out the sciatic notch. Sometimes that's piriformis and glute trigger points that are referring pain in a sciatic-like referral. Uh, in any case, once I establish that they're not in a new acute injury situation, then we do this. We do gentle, direct soft tissue work. And if you've watched my treatment videos, you know exactly what I'm talking about. From the knee through the hamstring, piriformis, glute, all the sacral fascia, the SI joints, all the way through the lumbar spine up to the thoracolumbar junction. Now, we cannot undo disc degeneration. We cannot undo facet arthrosis. What we can do is get blood moving, create a little space, get the nervous system to relax, and get the brain to stop interpreting all of the sensation from this part of the body as pain, and mobilize those joints. And then, of course, gentle traction. And for these fellows, generally, I recommend some home exercise, hip mobilizations. And to one of them, I recommended he purchase a lumbar traction unit for home because he was interested, asking about like an inversion table. Should he be hanging upside down? I'm not a huge fan of that. Your mileage may vary. I'm more a fan of gentle lumbar traction where you're not hanging upside down because of the hemodynamics and the blood flow to the brain and stuff like that. Another friend came in with foot pain, which was pretty classically plantar fasciitis. It's pain at the calcaneus, always worse in the morning. Came on a little bit slowly, like, oh, that hurts a little bit. And then a week later, oh, that still hurts. And then a week later, now that hurts more. And it had been going on for, I think, about 5 or 6 weeks, hurting to walk and feeling better if he wears nice cushiony shoes. So these are all, this is like the classic plantar fasciitis presentation. If you haven't seen it yet, you will. It's really important anytime there is foot pain, plantar foot pain, to rule out a neuropathy and a radiculopathy, which you could do with your exam and your history. The quality of pain in a radiculopathy and neuropathy is it's hot, sharp, spreading pain, whereas with plantar fasciitis, it's more of a tenderness, a soreness, and an ache. Also with a radiculopathy or neuropathy, you'll have weakness of the toe flexors and or extensors. You'll have positive nerve root tension signs and a positive Tinel sign. Whereas with plantar fasciitis, you won't have any of that. What you'll find is that when you, again, gently press on the calcaneal tuberosity and press into the plantar fascia, it's really, really sore and tender. With your palpation skill, if you have that database of palpatory experience, you can tell sometimes you can feel the bogginess and feel the swelling in there. You want to assess the mobility of the whole foot, ankle, and calf. It's all really, really important. You can't just focus on the painful area because you're looking at a closed kinematic chain from the toes all the way to the knee. So mobility of the forefoot, the toes, do they extend well? Are they really stuck? Are there hammer toes? Do the metatarsals have nice shear and rotation in relation to each other? Do those midfoot bones, the navicular and the cuneiforms, do they move well in relation to each other? If any of these are stuck, it's going to induce or worsen an existing plantar fasciitis. So work through all of that area. And then the calcaneus, we're very, very interested in the mobility of the calcaneus with any foot and ankle issue, but especially plantar fasciitis. Inversion, eversion of the calcaneus, as well as dorsiflexion. I've got videos I can link to in the description of me working on plantar fasciitis as well as degenerative discs, and I'll try to put cards in here so that I can link you to the right resource there. And of course, we're always interested in the mobility of the fibula, because if the fibula doesn't slide up and down, then the calcaneus is going to be stuck. And if the calcaneus is stuck, kind of the whole ankle doesn't work. So sometimes releasing the fibula is kind of unlocks the whole lower leg. And in order to release the fibula, we have to look at the tone and pliability of the deep calf, the gastroc and soleus. So again, when I say it's a closed kinematic chain, all those deep calf muscles and the gastrocnemius and the peroneals and the mobility of the fibula. All that affects the alignment and mobility of the calcaneus, which affects the tension on the plantar fascia. If the plantar fascia is hypertense for too long, it's going to start to avulse, even on a micro level. It's going to start to pull away from the calcaneus, and the body doesn't like empty space, so it's going to fill that space with inflammatory exudate, which is going to create local pain. So those findings were present in this patient. So we did a session on the affected calf and ankle. That was the left one. We also did a little bit of work on the right side just so it didn't feel too left out. And I gave him instructions. Wear soft, comfortable shoes. This is one of those times when I think it's nice to a little bit of ice. Rolling your sole of your foot on a frozen water bottle can feel really good for this. And calf stretches. And otherwise, I said, don't change anything else, right? I don't want you to rest it. I'm not going to put you in a boot. It's still a pretty mild case. You can walk. It's not altering his gait. It's just uncomfortable. And come back in 2 weeks and let's see how this is going. And then if it's getting worse, we could talk about maybe some more aggressive intervention, which he might need. Hopefully not. Hopefully this will do it. In any case, even when you do all the right things for plantar fasciitis, it can take weeks and weeks and weeks or months to resolve it because we're walking and standing on this tissue all the time. And it's dependent, right? And so stuff is just going to tend to pool and gather there anyway. Edema in the feet is so common. So preaching patients with any lower extremity injury, particularly plantar fasciitis, preaching patients. We also saw some shoulder injuries, as we often do in any bodywork practice. People hurt their shoulders all the time from injury and overuse and posture, and sometimes all three of those things conspiring to make the shoulder hurt. But we had a couple of mild shoulder injuries and one that was a little more severe. And when it comes to diagnosing a shoulder injury, it's pretty straightforward at the beginning, but it gets complicated as you get deeper and trying to be more precise with your diagnosis, which I think is pretty important. So always we want to consider, especially anyone over 35, is it possible that there's degenerative joint disease happening, particularly with the AC joint, the acromioclavicular joint, degeneration in that joint, creating spurring. If that spur is poking inferiorly into the subacromial space, that's going to be problematic and very difficult for any body worker to resolve or a physical therapist. Did a bunch of videos called Secrets of the Shoulder. I'll link to that playlist for you, where we talk a lot about diagnosing shoulder pain in great detail. So I won't go into much detail now. So you want to find out how long has this been going on? How long has the restriction of movement been going on? Those things are not always the same. Sometimes it hurts before it really starts to get restricted. And you want to ask, is it crunchy? Everyone's shoulder makes a little bit of noise when they roll it. But I'm talking about like real crunks and like really kind of a grotty sound when they move their arm. That's really different. If it's been going on a really long time and it's been stiff and the range of motion has been inhibited for a really long time and there's crepitus, you're probably dealing with some arthritis in the shoulder. That doesn't mean you can't help. It just would change the prognosis and change your goals. Once you have a sense of whether or not there may or may not be DJD underlying, you need to find out, is this a severe injury or potentially some inflammatory arthritis? Because inflammatory arthritides do affect the shoulder. RA, psoriatic arthritis, both do. Not so much gout, but the other two biggies. So severe injury and severe inflammation are not difficult to rule out. Again, when I say in the initial stages of shoulder diagnosis, it's pretty straightforward. How much movement is there? Is there swelling? How bad is the pain? Are there other signs of inflammation in the body? And is there a mechanism of injury? So if someone comes in and says their shoulder hurts, one of the first things I say is, well, how much can you move it? And if they're going like this, if they're doing that, I'm thinking, okay, this is not a severe injury, most likely. I mean, there are some people who can do that even with a torn rotator cuff, but probably we're not looking at a severe injury. And if it moves that much, probably the bursa is not super swollen, probably the glenohumeral joint is not super swollen, or the supraspinatus tendon is not super swollen, because if those things are super swollen, they're probably not going to be able to move it much past there. Okay, so just simple range of motion, how much mobility is there. And then look at it, put your hands on it. How swollen is this? Is it red and taut and like the skin is shiny? That's a swollen shoulder. You're not going to do body work on that. You're going to refer that person for some urgent care. But most of the time, it looks fairly normal. It doesn't look, like a big dislocation or a separated shoulder. Ask them, always ask everyone when they come in, how's your health in general? People generally know if they have rheumatoid arthritis by the time they come to see me. And how are your joints in general? And if they say, my joints in general have been good, my medication seems to be working, I'm avoiding my triggers, I don't think this is rheumatoid, they'll say, Dr. Russ. I don't think this is part of my psoriasis. I think this was from the deadlifts that I did or whatever it was, which brings you to the mechanism of injury. There isn't always one, especially with the shoulder, because our poor posture affects our shoulders so tremendously. And because there's so much overuse and repetitive strain in the shoulder. But if there is a mechanism of injury, people going to the gym, doing overhead presses, doing push-ups when they're not ready, stuff like that, it's good to know that. When it comes to imaging of the shoulder, if you just need to rule out or rule in arthritis, an X-ray is simple. It'll totally do the trick. It's all you need. If you're worried about some rotator cuff tears, then an MRI is your image of choice. If you're worried about something inside the capsule, like the labrum being torn, then MRI with contrast is really the best, because without contrast, you might well miss a labrum tear. So if you don't think there's a really bad injury and there doesn't seem to be a lot of inflammation, now, great, the simple part is over. We can treat the shoulder, but the question is, what exactly are we going to treat? So that's a matter of motion and static, palpation and assessment, muscle testing, and trying to determine which soft tissues are affected and in what ways. And of course, we have a whole long list of different things that happen to myofascial tissues. They get stuck together. That's an adhesion. They just get really tight and they're restricted. That happens to joint tissues as well. All these muscles in the shoulder are prone to developing trigger points because of how much they're used. And almost all of them, the trigger points refer pain distally into the arm. A lot of times active trigger points in the rotator cuff will not even hurt in the back of the shoulder. It's going to send pain out the front or even down as far as the elbow. There might be mild tears, right? Some repetitive strain, some accumulation of first degree strains. It's not dangerous. It's totally great for you to work on that. Get the shoulder to relax, improve the posture so everything can sit better, get the blood flowing through there. The patient's going to heal up pretty quickly. And then, of course, deconditioning, inhibition, and overuse, those postural and use patterns that can be really devastating for the shoulder. So in the case of the 3 or 4 shoulders we saw this month, 3 of those were pretty mild, and 1 was a little more severe. This was a fellow who I've been working with on and off for many years. He has a sacralization of his L5, so his low back gets tricky on him sometimes. He has a physical job. He plays golf. He's, does work around the yard and stuff. So he puts his body through it. But what happened during the ice storm we had in January was he slipped and fell and caught himself on the railing. And he came to me like 6-8 weeks after that had happened, and it was still hurting. So we've been working on it about a month, and once a week, maybe twice a week, doing some body work on it. But mostly I'm just counseling him to rest it. And he's been doing really well with it, but it's not getting better. So we're going to try and get some imaging going for him. And then we had an established patient with a history of a lumbar disc injury, like me, who came in with lower back pain and radiating pain into the posterior lower extremity on the left side. Continuous line of sharp, hot pain spreading from the base of the sacrum about down to the knee, occasionally going past the knee and pain in the lower back and stiffness in the lower back as well. I came into the waiting room to greet her, and I watched her get up off of the chair, and it was a kind of there is a very distinctive way that people with disc injuries get up off of a chair. Um, Gingerly and slowly. And basically, what they're trying to do is not go from the flexed hip to the extended hip really quickly, because that's the psoas needs to lengthen in order to do that. And their psoas is tight, trying to hold that disc. And so they don't want to just let their psoas go and stand up real quick. So she stood up pretty slowly. And then as we were talking and in the treatment room, and I was asking her, what's going on? You look like you're in some pain. And after about a minute and a half of standing and talking to me, I could tell she was getting really uncomfortable. And it was really starting to feel like a disc issue to me because of how uncomfortable, how quickly. And there's a way that discs hurt that creates panic in the body. And I saw her starting to look extremely anxious, not just physically uncomfortable, but mentally uncomfortable. So I laid her on her back. Um, After looking at like, how much can you move? Can you bend forward? Can you twist? And yeah, a little bit, but not much. Again, very, very gingerly moving. So then lay down on your back, please. And we did a straight leg raise. And at 25 degrees, we had a positive straight leg raise, which means pain in the lower back and leg is increased with the passive hip flexion between 15 and 50 degrees. That indicates the disc is irritated, if not injured. Not necessarily radiculopathy, but usually that's going to be a radiculopathy in there. If it hurts in the low back to lift the leg at all, that's probably not a disc injury, thank goodness. That's more of a lumbar or SI sprain, because the discs don't really start to move in that first 10 or 15 degrees of hip flexion. If you get past 50, 60 degrees and there's still no lower back pain or leg pain, and you get up towards 90, and then it starts to hurt, that's probably more of a hamstring issue. But anywhere in that 15 to 50 degree range, just as a general rule of thumb, that's not textbook, um, that makes me think disc. So that's what I thought was happening, and I told her. And now the main thing is we need to stop this from getting worse right now, because it had been getting worse for quite a few days, which has finally prompted her to come in. So first things first, I'm not going to do anything risky. I'm not going to do anything that's going to make this worse. We're not going to do any cracking. It's like jumping on a full water balloon, right? It'll go squish and bounce right back, and it'll be really angry. We're not going to be able to adjust this disc back in its current swollen state. So what we're going to do is we're going to just give it some time. We need to know, is this radicular pain or is it just the disc? So just in quotes, because even just a disc is really painful and can be hard to deal with. But if there is no radiculopathy, that is a really good thing. Sometimes the referred pain, even past the knee, is not from radiculopathy. It's referred pain from the disc itself. So there's layers of pain with any disc injury. We have the disc itself hurts, it's injured, it's swollen, it's red, it's angry, and it doesn't just hurt in the low back, it's going to send pain down the leg. Not usually past the knee, but sometimes. Okay. Then we have nerve pain from radicular squeeze, irritation in the intervertebral canal. That's pain down the leg, hot, sharp, spreading, scary, severe pain that you cannot ignore. And then we have muscle pain, because your QL and your psoas and your abs are going to be really braced, trying to hold everything in place. And over time, that hurts. And then we have the emotional pain, which is very real in all cases. But with disc, it's extremely scary. It's very frightening, creates a lot of anxiety. So whatever was happening with her, whether it was just disc or radiculopathy, it seemed to be getting worse, and it looked like there was a lot of inflammation deep in there. So these are my recommendations to her. Rest. We're going to do some anti-inflammatory measures, and you're going to rest, and we're going to do a little bit of gentle body work, and most of all, rest. So I put rest there 3 times, kind of as a joke, but also because it's really the most important thing. Don't stretch, don't exercise, just rest. It's like, imagine you had a pretty bad sprained ankle, when it's really swollen and achy and painful. you're not thinking what I need to do are some calf raises. What you're thinking is, I need to put a brace on this thing and put it up and maybe do some ice or alternating heat and ice and maybe some gentle massage, but mostly I just need to kind of give it a little bit of a break. So I did, we were able to do some side lying body work, quadratus lumborum, psoas, iliacus, abdominis, latissimus, the gluten piriformis, very gentle, because the goal here is we're not going to fix this today. The goal is we're going to get this to relax. We're going to get this body relaxed. We're going to get her used to being touched in this area gently so she can relax and let go, so that later, after the swelling has gone down, we can get in there and do corrective work because we've established that trust and rapport. So let's shift gears a little bit. Hey, by the way, I hope you like this video. If you're still watching, drop a comment. Let me know that you watched, what you liked about it. Do you want to see more of this? I have enjoyed putting it together, but it did take quite a bit of time to put all this together. So yeah, I don't know. Maybe I'll do this again. I kind of hope I do. So on the business side, we had 7 new patients this month, which is really good. I really like new patients, and 7 in a month is pretty good for me. We had a few regulars, and by regulars, I mean people come in like once every couple of weeks. Some who had been absent for a while, they've been traveling or dealing with other stuff, and they're starting to come back. That makes me happy. I like working with them. But April was definitely a nice uptick from a very slow March. So that felt good. I have created a new appointment type on my schedule. It's a 15-minute appointment on a sliding scale. So kind of bigger picture stuff, what's happening is that my practice is really still recovering from COVID, believe it or not. During COVID, especially in the beginning, I really didn't want to work. I'll admit it. There was a period of time during that initial month where I was like, I don't know if I'm ever going to go back. I was really enjoying all my leisure time. I was getting lots of sleep. It felt really good to get a nice long break from patient care. But I did go back, and I went back pretty slow. So like all through 2020 into 2021, getting vaccinated, I was seeing like 6 or 7 people a day max. Whereas pre-COVID, at the busiest time of my practice, was like a 12 or 13 would be a normal day, 12 or 13 people. It's pretty tired at the end of that day. And I didn't want to go back to being that tired. So through most of COVID, I didn't have front desk. It was just me and Kate, which was part of why I wasn't doing any videos. I didn't have anyone to hold the camera. But also I was just really focused on, well, survival, basically, like not getting sick and not getting anyone else sick. Of course, we all remember what that felt like. But, I was in close quarters with people, still 3, 4 days a week, and got kind of feeling like I was risking getting other people sick as well as myself. So when 2022 came around, I thought, okay, I think I'm ready to start to rebuild my practice, but I didn't. 2022 was a weird year for me, as I think it was for a lot of people. It just sort of came and went. And I really had thought that a lot more was going to change from COVID in that year than did. But in 2023, I was ready. And that was when I started doing more video. And I started also hiring a front desk person again and trying to engage, get my practice back to where it was before. So 2023 was a lot about the video. And now 2024 so far has been a lot about getting the practice back. So one of the things that I'm doing is trying to make it more affordable and more accessible. So having this 15-minute appointment type has been really wonderful. Number one, it's much more affordable, and it's as low as $60. It's a sliding scale, 60 to 90, and I really truly don't care what anyone pays in that range. There are even a couple people who are paying less than that, and that's great. It allows them to come in as often as they need. Because with the normal 30-minute appointment type, and the price kept going up during COVID because my rent was going up and all my expenses were going up and inflation, and everybody, we were all in it, until I found myself at the beginning of 2024, like I'm feeling like I'm pricing myself out of my patient's ability to access the care they need. So I created a new appointment type that is much more affordable and makes it easier for people to get in because they don't need a whole half hour of my time. And so I can see more people, and there's more slots and people are engaging with this new appointment, and they're taking advantage of the sliding scale, which really makes me happy because I know that they trust me, and I know that they trust me to give them the same care, whatever they pay. I really don't care what you pay. It's going to work out in the end. So that's been happening. And in this last month, as you can see from my channel, making more videos again, which feels good. So I have this scale of 0 to 10, and I'm going to kind of rate myself and how I'm doing in a few different dimensions. One is clinical confidence, 0 to 10, where 0 is I'm a complete idiot, and 10 is I can do no wrong. I can fix anything. And I'm feeling pretty good about that lately. I'm feeling like I'm able to understand what's going on with people. I feel like I've been referring appropriately. And I feel like I have been striking a good balance between being careful, gentle, conservative, and also being direct and trying to get to the root of problem for people. Otherwise, how's my energy? So confidence is really good. My energy on a scale of 0 to 10, 0 being I'm totally burnt, I'm a crisp, and 10 is I'm super psyched. I can't wait to get to work. I'm doing okay. I'm feeling pretty good. Sleeping well, which is enormous for me. I don't have any body pain right now, which is also enormous for me. I've been finding a good mix of social time. So I'm feeling like I'm feeling pretty energized. Connectedness to the patient. So energy is more like connected to me, and connectedness to the patient. 0, I'm tight, I'm brittle, I don't care. Why are you here? What do you want from me? And 10, warm and welcoming. I'm feeling really good. I feel supported in my work, feeling effective, and my energy is good. So how about the business? Where are we there? A 0, I quit because I'm broke, and a 10 is I retire because I'm rich. Maybe I'm a little bit joking there, but let's say a 0 is we're really struggling. I don't know how I'm going to make my rent. And a 10 is I'm feeling flush with cash. Maybe I'm going to go buy a new car. We're doing okay. Not as well as I would like to be doing, not as well as we were doing. Kind of like the peak of my practice was 2016 to 2020. We were all busy. I had 5 employees. It was fantastic. But that's not where we're at right now. It's me and 2 employees, and I like them, and we're doing well, but we could be doing better. We could be doing better. And I think we're moving in the right direction in the stuff that I was talking about before, trying to lower the cost for folks to come in, trying to make me more accessible. And I think I'm in a good place in terms of my energy and my confidence and my competence. So we're moving in the right direction, but we're not at even a 7 yet. I would say we're a 6.8. So that's my video, Touching Base, Volume 1. I hope you enjoyed it. You're still watching. So thank you so much for watching and being interested in what's going on with me. And if you came for the sleep, I hope that you are sweetly and comfortably in dreamland. Otherwise, this is Dr. Russ signing off, and we'll see you again really soon.